Hello, everybody, and welcome back to the Ketodontist podcast. This is your host, Dr. Matthew Standridge, going to be talking about dental crowding, nasal breathing, and high-protein diets. So let's get started. Now, it's important to remember that this show is for education and entertainment purposes. What I could say here does not constitute giving dental advice or dental care. So if you do have issues finding a dentist that will kind of take a more functional approach, let me know, and I can maybe try to find someone to help you out. So anyway, so I've been getting a lot of questions lately about dental crowding and basically why it happens and what we can do about it. Is orthodontics the only thing that we can do about it? And I wanted to kind of go into a little bit of the different theories of why we get dental crowding in the first place, because I find it very interesting. And I do a lot of orthodontics in my practice. I do traditional, brackets and wires. I do those on kids, teens, adults. I do Invisalign on adults, and even more so on teens and kids now. I do myofunctional therapy and all sorts of like removable interceptive orthodontics. And so orthodontics is a passion of mine, and it's something that I've really grown to enjoy, and it's my favorite part of practice as far as the clinical dentistry side of things go. And so yeah, I could geek out about this for a long time. But we talk about dental crowding, and what can we do about it? Well, that's going to be age specific, because there are some folks in the like myofunctional therapy camp that think that if you just get kids chewing right and breathing right and doing these tongue exercises, maybe using a myofunctional trainer, or it's like this little mouthpiece that puts the tongue in the right position, teaches kids to swallow, all that stuff, that at any age that's going to be good. And I kind of disagree with that to an extent. So we'll go into all of that here in a little bit. And then the nasal breathing side of things is because really there's a lot of focus on sleep. There's a lot of focus lately on airway. And again, those are things that I am passionate about. And the big part I'm passionate about that is because I'm affected, myself, with these things. And I want to give my take on kind of the things that we can do, but also root causes of this stuff. And then lastly, high protein diets, because there's a great study that I just came across that's pretty new, and really showed the importance of protein in the diet and its effects on body composition. So with crowding, why do we get crowding in the first place? And, back before I knew anything, I just thought that was kind of genetically driven, and that we would, some people were just designed to have crowded teeth, and some people weren't. There's also the theory of, with like, interracial blending of families and stuff like that. And if you have a or even not even just interracial, even though that's a big part of it, but like even just physical attributes wise, you have a 6'2" father with big large jaws, and you have you have a 5'5" foot wife with little dainty teeth and jaws. And if you get dad's big teeth but small jaws, you're going to have dental crowding. And that's honestly how a lot of folks still look at it. But after really diving into the research, going through anthropology, all this stuff, I don't think that's the case. I really don't. And so but there's a lot of people, a lot of medical doctors, a lot of dentists, a lot of people, that still think that that's the deal. But after learning about facial growth and development, how our environment impacts that, how our food impacts that, how, different things like having a correct swallow, nasal breathing, all of that stuff affects over time the shape and the growth and development of our teeth and jaws. It really comes down to that. Now, in this kind of holistic alternative medicine approach, they have basically two trains of camps. You have the Weston A. Price camp where, he went, and when he documented all these primitive cultures, they not only didn't have cavities, but they didn't have dental crowding. They had nice broad arches, broad smiles, room to fit all of their teeth, including their wisdom teeth. And they were attributing that to the diet, and you're getting adequate diet. You're not getting a bunch of anti-nutrients that are stunting growth. You're not getting, sugars and processed grains that are carcinogenic, that are stunting growth. You have plenty of fat-soluble vitamins, all of this stuff, right? So that's kind of the Weston A. Price camp. And then there's a book that came out a couple years ago. I forget the authors. It was named Jaws. And no, not the shark, but it is about jaws, the growth and development of our jaws. And in that, they attribute it more to this myofunctional, lack of nasal breathing, lack of chewing hard foods and chewy foods that, cause the bones to want to develop and to grow, and they talk about the tongue and all that stuff. And they were thinking from that approach but then they kind of poo-pooed the diet side of things. They poo-pooed the Weston A. Price of things. And really, I think it's both. I think it's both camps. It's kind of like, to me, how I am a personal trainer also and all that stuff. And you talk to people about lifting weights, right? And, well, you need both that stress response. You need that physical stress in order to grow. So yeah, we need to be eating chewier foods. We need that tongue and, to help shape that palate and all of that stuff. But then we also need the building blocks from food to grow. And we need those fat-soluble vitamins, and we need to stay away from anti-nutrients and all that so that way we get the optimal growth. So it's just like, you can't get jacked just eating protein shakes. You have to actually physically do the work, but at the same time, you can't lift weights for 6 hours a day, but not get the adequate nutrition and expect to grow. And so to me, it was kind of an unnecessary butting of the heads, because I'm like, I think you're both right. I think we need both. And so what's interesting about the growth and development of the jaws is that really this starts when we're very, very young. This starts when we're newborns and we start breastfeeding. And this is what's kind of crazy about it, is because even going back and seeing the shape and the arch development of kids that were breastfed versus bottle fed can lead to a huge, huge change between those two. Because what happens is with breastfeeding, the breast takes up more of the mouth, and it fills the mouth more. The tongue has to work to push up, and latch on, and then that pressure of that latch of that tongue pressing up on the breast helps kind of flatten and widen the palate. Well, here's the thing. When we do that, when we the palate, the shape of the palate is also the floor of the nasal cavity. And so if we have a very high vaulted palate like I do, that's going to encroach on the nasal airway. And so these kiddos that are breastfed, and even up to 2 years is what they suggest. I don't know anybody personally that has been able to breastfeed up to 2 years, but that's kind of where folks are suggesting that we breastfeed up to right now is up to 2 years. And what that does is that helps develop the tongue to be pushing up against that palate. It pushes the breast up against that palate. And because of that latch, these babies have to learn to breathe through their nose. And nasal breathing is so important. We're going to be talking about that soon. And nasal breathing, it's kind of interesting because with the muscles and the soft palate and back in the throat and everything, if we're not nasal breathing, those kind of get saggy and drop down. And it just further increases obstructions. Yet if we can learn to nasal breathe and get that muscle tone back, it kind of goes away. So it's a use it or lose it type thing. That's really, really interesting to me. But anyways, going back to babies. So, were these kids being able to be breastfed or not? And some folks just can't breastfeed for whatever reason. And I completely sympathize with that. I don't know the reason, but I was bottle fed exclusively. I was not breastfed. Well, what did that lead to? That led to these, what's called narrow buccal corridors. So our teeth we should have nice wide smiles. Folks with a narrow smile means they have narrow arches. And that means we're going to be more prone to having crowding and issues like that. And then also, like I said, that, and if you think about it, think about how, latching, how a good latch, how you fill the mouth, a lot with the breast, that's going to take up a lot of the oral cavity, and it's going to have kind of a flattening effect, right? Well, compare that to a pacifier. And what's the muscle action going to be on a pacifier? Or stuff like these little squeezy veggie pouches and fruit pouches and stuff like that. It's a narrow, it barely takes up any of the oral cavity. It's a narrow opening, a narrow volume. And instead of the tongue having to work against the palate, it's creating a sucking motion that's causing the cheeks to come in. So almost like if you try to make a fish face and you suck your cheeks in, that is the action that is going. So these muscles do dictate how our growth and development happens. And so when we're on bottle feeding or a pacifier, how many kids are given pacifiers? And it's to help soothe them, and it's to help, it's to help relax them and all that stuff. But at the same time, they're kind of just little mute buttons, right? You're crying, here, boom, pacifier, and that's it. Well, that creates this constant sucking in motion that there are some pacifiers that are designed to help train the tongue, but they're harder to do. Kind of like breastfeeding can be harder to do than bottle feeding. So a lot of folks will just go with the easier route and use these narrow pacifiers, narrow bottles that create this cheeks, the sinking in of the cheeks. Well, that repeated all day, every day is setting these kids up to have narrow arches. And if we have narrow arches, then we're going to have less space for the teeth to align properly. So, and this, like I said, this happens when we're newborns. And so then we get put on this path then, and then how do we continue to grow from there? And there are things like, our kids' mouth breathing versus nasal breathing. Most kids, most adults are mouth breathers. I still have issues, even though I know better, because it was it's been trained in me my whole life. I was a big, obligate, mouth breather. And I just didn't know any better. I've gone through training. I'm still training myself to nasal breathe, but a lot of folks are mouth breathers. It's kind of interesting. And, if you watch the, season of Stranger Things, I think it's the first season, and, the kids are being picked on, and they call their bullies mouth breathers. But when you look at these kids with their crowded teeth and all that stuff, and very poorly defined nasal muscular structure and all that stuff, it's like, well, it's kind of interesting that they use mouth breather as a derogatory term, but like a lot of these kids were mouth breathers. And that's not to pick on them, because we all, not all, but most of us are probably more mouth breathing than we'd like to realize. So that then leads to, because we're not using our nasal airway, that we get less nitric oxide production. Nasal airway, I'll be going into that in a lot more about why nasal breathing is so important. But are we going to get proper growth and development there? Of course, there's the food issue. Are we getting, or do we have a high carbohydrate, high sugar, high grain diet, lots of anti-nutrients, not a whole lot of fat-soluble vitamins? So are we going to really grow to our genetic potential using such a standard American diet? So there's that, coupled with the mouth breathing, coupled with our tongue has never really been trained how to swallow. And so in a proper swallow, your tongue fits against the roof of your mouth, and it seals it, and it rolls the food back. Well, do that how many times per day, every day, and that creates a widening, flattening effect of the palate, which is a good thing, because again, that's increasing the width of our dental arches, so we're going to have room for our teeth. That helps develop also the nasal cavity, all that stuff. So you're going to see how all of this stuff is connected. So we go from there to how much of this is being, like, when can we correct this? Okay. So, up to, I would say 4 or 5 years old, depending on the crowding and stuff. For me, I would really like folks to be looking at myofunctional therapy. There are some stuff that you can look on online. I like myofunctional trainers myself. They're like little gel mouthpieces that help keep the cheeks and lips off of the ridges, and it has a spot for the tongue, and you have to have good lip seal around them. Now, it's really important that if you're going to do the myofunctional therapy thing, don't cheap out. Look for a qualified myofunctional trainer. Depending on what part of the world you're in, some myofunctional trainers can operate on their own. Here in the States, at least most of them, I think, a lot of them work in dental offices or dentists themselves, and their teams can get trained and become certified trainers, and that's what we did in my office. Is I went through the training, and I use a system called MyoBrace. And later this year, I'm looking to get certified in a system called Healthy Start. Kind of Coke and Pepsi, they both have pros and cons, but kind of just depends on what you're looking for. But yeah, don't cheap out. Go to somebody who knows what they're doing, because the style of the appliance plays a big role. The coaching and demonstration of the exercises and follow up and all that stuff plays a really important role. So up to, about 4 years old, maybe up to 6, I like the myofunctional therapy approach. But after that, depending on the severity of the case, sometimes we just need to get in there with something a little bit more, I don't want to say predictable, but intentional. And that can be through actual brackets and wires or aligners or something that is removable, but you keep it in when you can and all that stuff. And there's tons and tons. I can't even begin. It would take me 3 hours, a 3-hour podcast just to go through all the different types of appliances. So we're not going to do that. But after age 6, if they are still having crowding, I used to be part of the wait and see tribe. There's so many in orthodontics that are just like, let's see if they outgrow it. But over the last decade of doing that, I've come to realize that these kids just aren't going to outgrow it. And a big reason is because a lot of the behaviors that have been going on to lead up to this point aren't changing. Well, if our diet and our nasal breathing and our myofunctional habits and stuff, if they're not changing, why would they outgrow it? Why would they just spontaneously outgrow it? That can probably happen maybe sometimes, but that's not the norm. So I've become a lot more intentional, a lot more focused on getting in there and resolving the problems. Now, going back to myofunctional therapy, as far as when I talked about up to 4, maybe 6 years old, that's as far as it being able to correct the problem itself. I still believe myofunctional therapy could be beneficial for almost anybody at any age. It's very, very low risk. To me, there's nothing but potential upsides to it. There's nothing that, unless if a person is prescribed a wrong appliance, if they're going through an appliance approach, unless if somebody is prescribed or given a wrong appliance. Other than that, there's no downside of it to me. And really, to me, it's just replacing what we should have been. Like, what we've lost in modern society with breastfeeding, with eating hard and chewy foods and all of that stuff and getting that mechanical stimulation, it's just replacing what we've lost there. And so I really think all kids, vast majority of them, should be on doing myofunctional therapy, and a lot of adults too. It's kind of interesting. There's a study, and I'll bring it up in a future sleep apnea presentation I'm going to give. But adults with obstructive sleep apnea had just going through myofunctional therapy saw reduction in their sleep apnea severity just by going through myofunctional therapy, not even including the CPAP or anything. So that's really interesting, that how beneficial it is across all ages. But as far as correcting orthodontic issues solely, I've tried it in 6 and 8 year olds. Maybe there's compliance issues, I don't know, but I think by the time we're getting to 6 and 7, that we are starting to get a little too down that path that myofunctional therapy by itself is going to correct. Now, there's going to be some folks that teach on the myofunctional circuits that they have their highlights, they have their highlight reel that they show the same 5 cases to and have done so for years. But I'm talking, and so it can probably be done, but for the majority, I would say up to about 4 or 5 years old. After that, we're going to have to start looking at something else. And so then at 6 and plus, it really depends on the severity, because sometimes we can wait. If it's just more cosmetic and there's no other issue going on, no airway issues or anything like that of concern, then, if it's just more cosmetic, then we might be able to wait. But a lot of these kiddos, that if they have a good amount of crowding or they have a lot of deep bite or something like that, I'm getting in there and getting stuff taken care of early, and oftentimes combining that with myofunctional therapy. So that way, not only do we correct the tooth position, the arch width, promote nasal breathing and all that stuff, but we're also retraining the tongue and the cheeks and the lips and all that stuff. So that way, the stability of our case thereafter is going to be a heck of a lot better. So, speaking of airway, pediatric airway is something that is sorely underdiagnosed in our country, and I'm betting the world. You know, these kids that are being put on ADHD medications and all that stuff, and they can't sleep, and they are still bedwetting and stuff like that. These are all red flags that they can't breathe in their sleep. They're not getting adequate sleep. And that could be because of a number of reasons. It could be because of tonsils. It could be because of adenoids. It can also be because their airway just isn't large enough. And that could be their upper airway, their nasal cavity. Well, again, if they have really skinny arches with high palates, then their nasal airway is going to be compromised. If kids brush their teeth, that is a big indicator of an airway issue. And same thing with snoring. Snoring with any kid is not cute and it's not normal. And so these are all things that, unfortunately, to me, a lot of orthodontists have missed out on. Now, not to get on a soapbox right now, but I am pretty anti-extraction orthodontics. I've done it in some cases, but it is definitely not my preferred. And so many people have been, have had premolars taken out to make room, quote unquote, make room for the teeth to be straightened. And I think that's asinine. And while there's no studies to quote unquote prove that compromises the airway, intuitively to me, I can't see how it does it. And really, a lot of these people that tout that a lot of orthodontic societies that tout that extractions have no proof that it compromises airway, that's kind of more of a CYA, a cover your type of lip service to me. So I'm very firmly non-extraction orthodontics. And so in that case, then what we have to do to make that work is to help grow the arches and give them just space naturally to house all of the teeth. And up to about 10 to 12 years old is about that time, up to that point that we can kind of maximize that genetic potential. After that, and we get into our later teen years, we start to lose that. And then also, like palatal expansion becomes less predictable and all that stuff. As that suture, there's a growth suture in the middle of our palate that starts to close. It starts to become fibrous and hardened. And so, and after 18 years old, that becomes very, very tricky to reopen. So that's kind of, long story short, with the crowding, what's our diet look like? Are we breathing through our nose? Do we have any signs of like snoring, teeth grinding, that type of stuff? Because if not, then we're not getting adequate sleep. If we're not getting adequate sleep, we're not going to grow properly. Just all of this stuff is intertwined. And so, really be looking at that. And depending on the age is when I'm going to depend on when they see like a trained professional, like a dentist or an orthodontist. If the dentist is doing it, they need advanced training in orthodontics, or else go to a licensed orthodontist. But even then, some of them are more reactive, some of them are more proactive. So you kind of want somebody who is okay doing interceptive orthodontics if that is what's needed. So moving on from crowded teeth to nasal breathing. So I posted a picture on Instagram about my nightly routine, and I had my blue blocker glasses on. I had a nasal air, a breathe right strip, and I had what's called a Herbst appliance. And traditionally they were used in orthodontics, but they can be used in airway management as well, because it helps posture the jaw forward and keeps it from moving back while we sleep. And so I have figured that I've had some sort of sleep apnea for a while, since I started about 5 years ago going down my sleep education. And a lot of the check marks, what they were talking about with sleep apnea patients, things to look for. Big one is clenching and grinding our teeth. Well, I'm a heck of a clincher and grinder. I've been a clincher and grinder all the way since I was a kid. And 5 years, I've been grinding since I was 5 years old. Well, turns out that's not quote unquote due to stress like we thought it used to be. No, it's more than likely an airway issue and a sleep airway issue. And also stuff like what's called tori, which is this excess deposits of bone in the jaw, and that is laid down because the teeth are taking such high stress, oftentimes at night, and this is nocturnal, so we're unconscious during this, so we're not aware that this is happening. Well, I have these huge buccal tori up here, and it's a big part is because I'm a huge clincher and grinder. And I have a high vaulted palate, so our palates should be kind of flat and narrow. Mine is very more like V-shaped up top there, so it's very, very high, almost like a tint up there. And so I was going through classes and it's checking all these boxes, and I don't feel all that refreshed when I wake up and all that stuff. So I'm like, dang it, I bet I have sleep apnea. Well, recently, because we're starting to treat this or manage it more in our practice, I do a lot of surgeries and stuff like that, but I also like to do a lot of orthodontics. Now we're getting into sleep management, and I'm probably going to be phasing a lot of my surgery side of things, extractions, dental implants, reconstructions and stuff, more towards advanced orthodontics, and then also sleep, oral appliances to help manage sleep apnea, because really that's where my passion is. So we got a home sleep tester. It's this thing called the MediBite Junior. It fits on your chest with this strap, has this effort belt so it can tell when you're trying to breathe, when you roll over, all that stuff. Has a pulse oximeter, a little finger cup pulse oximeter, so it can read your oxygen levels and read your pulse rate and all that stuff. And then it has a nasal cannula, so it can tell when you're breathing and all this. And so it's a pretty slick little device, and we're able to get some pretty good quality sleep reports, not as in depth as like folks who go to a sleep lab do, because they get like the little electrodes onto their head and onto their scalp and stuff, and you can measure brain waves with those and all that stuff. But for a good kind of screener, as far as when people desat, meaning when they lose oxygen, when they stop breathing, all that stuff, this is a great tool. And so I took it home and put it on me. We did a study on my wife. We've done studies on every employee except for one thus far. She just hasn't had a chance to take it home yet. And sure enough, we all have some level of, I'll go into this here in a second. According to the report, we all have an AHI above 5. So not to get into the sleep reports by a whole lot, but as a dentist, I can't quote unquote diagnose sleep apnea, but I can send folks home with a sleep tester and I can run the report and I can share the numbers with them. But it's kind of interesting because they with the scale, this AHI, this apnea hypopnea index is basically saying how many times did you stop breathing during the night? And what's that average per hour? So if it's 5, then you stopped breathing 5 times per hour on average. If it's 20, you stopped breathing 20 times per hour. You know, all this stuff, right? And not to go into much on the AHI because it's a flawed system in many ways, but it has some merit. Anyway, so I would be labeled moderate according to the report. Again, I can't diagnose. But I had an AHI of 24, if I remember right. So that means an average of 24 times per hour I would be stopping breathing and I would desaturate at least 3% in my in my blood oxygen levels. So, I mean, that's pretty disconcerting, but here's the thing, that's been going on all of my life. I know it has because I've been grinding and stuff since I was a kid. So I know, and I developed these tori and all that stuff. So I know this has been going on my entire life. So that's why I wear I took this picture with the nasal strips and all that stuff. And if we could honestly do one thing for our kids and for ourselves, it would be to practice nasal breathing. I truly believe that. Every person, I don't care how old you are, go to bed with a nasal strip on. Just to help promote nasal breathing. And especially if folks have a CPAP or a BiPAP machine or something like that, you should definitely be wearing a nasal strip. So, we don't really think about something, until it becomes overwhelming. And I see that as like sleep apnea. I see a lot of kids, teenagers, and adults with sleep apnea. And if we could just get to the root of this earlier, maybe we could prevent some of this. And I really think nasal breathing plays a huge part in it because the nose performs tons of functions while we're breathing. It humidifies and it warms the air before going into the lungs. It helps filter out larger particles, and so that helps protect our airway. And, we can mouth breathe, but the oral tissue is not capable of, it doesn't filter anything. So we're getting this dirty air into our lungs. Do you think that maybe that has, sets people up for more things, more infections and that type of stuff? If breathing through our mouth dries out our mouth, well, then we lose the protective functions of our saliva. So then are we going to be more cavity prone and all of that stuff? And, are we congested, and why are we congested? Is it because of inflammation through our diet? Is it just because simply we're not breathing through our nose? Like I said, nasal breathing, the musculature and all that stuff, that is a very use it or lose it type thing. Also, when we mouth breathe, our mouth is open, so our mouth is open and then goes back. And if we're doing that while we're sleeping, then that also impinges on the airway. The tongue is then positioned closer to the back of the throat, and so that narrows the airway. But then also, because it's in this lazy position, we lose this muscle tone in what's called the genioglossus muscle, which basically helps keep muscle tone for our upper airway. So if we lose that muscle tone, then that upper airway is more prone to collapse. And you can see how this is just a domino effect, one after the other. Children with mouth breathing, like I said, they narrow arches, high arch palate, can lead to cross bites, under bites, all this type of stuff. And my biggest thing with nasal breathing is nitric oxide, NO, nitric oxide. It's a neurotransmitter to the lower airway that causes airway dilation. And then there have been studies to show all of these different effects of nitric oxide in the body. It's a very widespread signaling molecule. And, nitric oxide, it helps promote the vascular tone in our blood vessels and the smooth muscles of our blood vessels. It helps leukocyte adhesion and platelet aggregation. So how well we clot is promoted by nitric oxide. It helps with dilation of our blood vessels, and it helps decrease hypertension and atherosclerosis. For men, what is the most common drug treated for ED, for erectile dysfunction? It's Viagra. What does Viagra do? Helps upregulate nitric oxide. And so nitric oxide just plays a huge role in our overall health, and it's a signaler to all these metabolic processes, but we are not getting it if we are not nasal breathing, or we're not getting it in quantities that we should. And so that's why I really want folks to focus on, first, breathe through your nose. I get a lot of questions about mouth taping. That's kind of the new hip thing that every influencer and their mom is taking pictures of themselves mouth taping. I'm okay with that to an extent, but first I would recommend training yourself to breathe through your nose using something like a nasal strip or a nasal dilator. There are a few different options. I just use the cheap little Breathe Right strips from Walmart, and they work fine for me. I couldn't stand having the nasal dilator, which basically these little rings that go inside the nostril and help hold them open. I just couldn't get used to them. I've tried and tried and tried. I've did different sizes, different types, and I just keep going back to the strips because that's what works for me. But you can do whatever that works for you. But if you're going to mouth tape, I would totally recommend doing a nasal strip first, see how you do, then try to use the mouth taping. Mouth taping scares me a little bit for a reason that if folks have a true obstruction, which a lot of folks do, then mouth taping I could see be very a potential for a lot of harm. I really do think that. Now, some people, they don't have true obstruction. They just have more like upper airway resistance syndrome, UARS for short, that if they just practice and train, breathe through their nose, maybe they can overcome that. And so that's worth a try, but I would really recommend working with a trained professional in a lot of this stuff, because our sleep and being able to breathe in our sleep is just not worth the risk to me, And I'm sorry, folks, but sleep is a third of our life, and it's not something that we want to skimp out. Somebody on Instagram had mentioned that they're surprised I don't wear an Oura ring. Because again, that's all the cool people do, right? But those things are like $300, and I got away from gadgets. I have no gadgets except for my smartphone. I don't have a step calculator. I don't do all of that stuff. I got rid of my Fitbit, all that stuff, because I know if I'm eating right. I know do I wake rested or not? Do I get movement in during the day? I've just kind of unplugged from a lot of that stuff. But I would be interesting to see that might be an experiment worth doing anyways, getting an Oura ring, getting what the results are from that, and then doing a home sleep test as well, and getting the results from that and comparing the two to see what that's like. I think that'd be interesting, so I'll probably do that. But anyways, so to finish up today, I want to talk about this study that it is called The Effect of 12 Weeks of Ecocaloric High-Protein Diet in Regulating Appetite and Body Composition of Women with Normal Weight Obesity, a randomized control trial. Okay. So this was published in the British Journal of Nutrition, and it was put on by the Nutrition Society, Advancing Nutritional Science. So anyway, so what they took, I didn't know this NWO was a thing. Normal weight obesity syndrome is associated with metabolic diseases. So what they did is they took a 12-week program and they did a randomized control trial, and they took 50 participants and put 25 on a high protein diet, 25 on a 15% diet. So what constitutes standard diet and high protein? High protein meant that 25% of their calories came from protein. For the standard diet, standard protein, that was 15%. So you have 25% for high, 15% for standard, okay? And then they measured, but again, calories were equal, okay? So again, did it for 12 weeks. They looked at weight, they looked at fat mass, and they looked at lean body mass. They looked at waist circumference, and then they looked at appetite. And that was obviously a bit more of a subjective thing. So they put them on equal calories, but one had more protein than the other. And then, so here's what was interesting. So after the 12 weeks, the lean body mass was higher in the high protein group compared to no significant changes in the standard group. So the high protein group increased their lean body mass. And then in the high protein group, they also had lower fat mass and body fat percentage and waist circumference. So increased lean body mass, good thing. Lowered fat mass, good thing. Lowered body fat percentage, good thing. Lowered waist circumference, good thing. At the end of the study versus no significant difference in the standard group. That is huge. And then what's really interesting. So in both camps, weight and appetite did not change over time with either diet. So high protein and standard protein, neither of them had really a change in scale weight or appetite. But it's so interesting that the high protein diet significantly improved body composition. Even though their scale weight didn't change, their lean body mass went up, their fat mass went down, their body fat percentage went down, and their waist circumference went down, even though the scale didn't change. So that again goes to show the importance of adequate protein, or even a little bit higher protein in the diet and its benefits. That's why I practice more of a low carb, high protein version of keto than a lot of the people who think that keto, or you can't have too much protein in keto, and if you eat too much protein, it just turns to sugar. And sorry, folks, if you want healthy fat loss and you want optimal body recomposition, eat your protein. I'm serious about this. That's a reason why I keep talking about this, because so many of the keto zealots are afraid that protein is going to turn to sugar. I don't care if it turns to sugar or not. If I want to going to be able to increase my muscle mass, decrease my fat mass, have great changes in body composition, then that's what I'm going to do. And time again, higher protein diets have been shown in the scientific literature to be effective for these things. This is just the latest one because it came out like less than a month ago. So anyway, make sure, don't listen to the folks saying that you need to, you're not in ketosis, you need to lower your protein. Again, unless if you're trying to be high ketosis for some sort of, epilepsy control or some sort of adjunctive cancer therapy or whatever that is, if you're looking for fat loss, not just weight loss, we're really wanting to lose fat. If you're in this for fat loss, do not be afraid of protein. Okay? So we're coming up on an hour. I hope you guys enjoyed the show. Thank you so much for being here today. If you like today's show, please like, subscribe, share. It's been a while since we've gotten a written review. If somebody could drop me a review or a rating, that would be much appreciated because we're really trying to cut through a lot of the BS and a lot of the dogma that is going on in these keto, paleo, low carb spheres, all these influencers with their sound bites. We're really trying to cut through all of that noise and give real science fact-backed information and real take-home effects that people across all walks of life can do. So again, thank you guys so much for showing up today and listening. Really appreciate it. And until next time, eat, move, smile. Later.